let's move on because we still have a few things to discuss. Omid, what other combinations are you excited about? I mean, I was told there are 1,000 immunotherapy combination trials, not in melanoma, in all histologies. So the actual number was 1,040 combination trials. So of those 1,040, what excites you? What are your top three?
Well, you can't go forward without saying where are those combinations. And I would like to just talk about what's available through the cooperative groups, because that's available in the communities. And they're looking at TVEC plus PD-1 in patients who have failed single-agent PD-1. They're looking at IPI and NIVO in those patients who failed single-agent PD-1. So just a little blurb for the cooperative groups and the trials that are available. The Nectar drug with nivolumab has shown some initial increases in disease control and response, although, again, given what some of these recent trials have shown, we have to be a little cautious about moving forward and declaring a winner. I think that combination needs to be looked at further.
That's a pegylated IL-2 molecule.
That's right. Yeah. So all of these combinations are interesting. I guess what's now really most important to say is that they need to be biomarker heavy. They need to help us understand how to take care of our patients who have not only shown up de novo, but have progressed on single agent. And then as we move forward, we have to be cautious to move forward in the right way, which would be randomized phase 2 studies to try and find really the benefit. Because what we've talked about on all of these combinations now is that we're in a different landscape. The numbers can seem better, but we have more therapies. Survival has improved. We'll be presenting 5-year survivals with PD-1 that indicate how far we've really come from what we really thought 5-year survivals were. And the data are in flux.
And so finally, Hussein, what about the triplets? I mean, what do you like there? I mean, there are 3 triplet trials, the Trilogy, Combi-I, and Keynote 022. Which ones, or do you like all of them? Are they going to be very similar?
Well, I mean, you know, the biology of why you should combine BRAF/MEK inhibitors with PD-1 antibodies is quite solid. We know that BRAF targeted therapy was initially developed with the idea of just targeting the BRAF, the MAP kinase pathway and leading to direct cell kill that way. And obviously, it turned out within a very short period of time that you actually modulate the tumor microenvironment quite significantly by increasing T-cell infiltration, changing tumor antigen expression, and actually modulating a lot of the tumor and microenvironment cytokines. So it's a lot of things that point to the fact that this is actually, that there's an immune mechanism of response to BRAF/MEK. And specifically, there was evidence that actually PD-L1 gets re-expressed and increased expression after BRAF/MEK. So the concept of adding a PD-1 antibody made a lot of sense. And the phase 1 trials that were done, some phase 2 trials, and actually some of our own experience have been really impressive in terms of response rates. So the response rates have been higher than traditionally known with the BRAF combination alone, and, you know, kind of higher, even, you know, north of 85% in most of those combinations. But they're taken to the phase 3 setting now, appropriately so compared to BRAF/MEK alone. So when I think about which one is going to be my favorite one, that's when you turn your attention to the next question, which is 3 drugs are definitely going to be more toxic than 2. And the toxicity piece has been a quite important aspect of this. We definitely see an increased rate of fevers, for instance. We just spent some time discussing how BRAF/MEK combinations have fevers in up to 50, possibly as high as 70% of patients. With the addition of a PD-1, those rates appear to be even higher. And those fevers tend to be also recurrent at what appears to be a higher frequency as well. There's some liver toxicity that's also involved. So I think once we see the results of these phase 3 trials, we will be able to have a better sense of what is the differential activity, but then we will really have to take a close look at the toxicity and its management.
Also the point that Jason made about neoadjuvant approach, also it relates to this. The triplets now are only in clinical trial, and I would never put a patient on in the community off trial on this triplet approach at this time. We don't know if it's any better. We don't know if it's any worse. So,
well said.